Hiza. Hiza nak tanya.
Ya.
Hiza ni ke? Share slide lagi ke?
Sekejap Try. Nampak ke?
Ya, dia tengah share. Sebab saya ada buat video. Saya risau pula takut dia tak boleh play. Next.
Syairah ni ada share dekat group kan?
Pasal dekat video tu. Dia tu. Boleh play ke? Sebab saya nak play dekat main, dia macam kat tengah jalan tu. Dia macam dekat minit ke-5 macam tu. Boleh ke? Kalau tak boleh, sebab kalau tak boleh buat, nak minta Hiza. Maksudnya pergi dekat new tab lah, buat new tab.
Dengar tak?
Tak ada suara.
Dengar tak?
Dia dengar tapi macam lagging lah. Hiza try, salah sebab ni bukan Google Meet lah. Tak apalah, kalau catheterization pun dekat minit ke-5 dia tu.
Dengar tak?
Dia dengar suara dia tapi lagging lah. Macam kita tak boleh dengar dia cakap apa. Tapi tak apa kot, saya explain je lah. Dia tu.
Okay.
Thank you, Hiza.
Siapa present? Dah ada semua, siapa present?
Assalamualaikum. Okay, everyone here.
So year apa? Year 3.
Year 5.
Year 5. Group 2.
3.
Group 3. Siapa present? Siapa dulu? Siapa ni?
Saya Zakira. Zakira.
Apa?
Zakira.
No Zakira. No Zakira ke Zakira?
No Zakira.
No Zakira.
Ya.
Semua ada dah?
Ada.
Apa topik you present?
Saya present central line insertion.
Okay.
So let's start our presentation today. So this is a list of procedure. Okay, so I'll start first for the central line access. Okay, next. So this is a table of contents. So I will start with location and site of insertion, indication and contraindication. Okay. Okay, next section 1. Next. Okay, so there are various sites for central venous access. We can do central venous access through peripherally inserted central catheter, usually through cubital fossa vein into superior vena cava. Next, we can do through femoral vein, external and internal jugular vein, subclavian vein, and also umbilical vein or arteries. Next. Okay, first, for peripherally inserted central catheter, PICC, this is usually is a mainstay of vascular access in the neonatal intensive care unit. Okay, so we can reach the central vein through either upper extremity or lower extremity. So for upper extremity, usually via cephalic vein, and lower extremity via saphenous vein. So the distal tip will be in the large central vein. Okay, usually indicated for children who require intermediate term IV access for prolonged home or hospital therapy, such as in chronic infection, cancer, or parenteral nutrition dependency. Okay, next. Next, for central venous catheter, it could be inserted into femoral vein, subclavian, internal or external jugular site. And this procedure is usually done with ultrasound guided. The femoral vein is more preferred because it has more advantages compared to others, because it can be placement of temporary hemodialysis or pharesis catheter, inaccessibility of other primary central vein as a consequence of thrombosis or stenosis, and during cardiopulmonary resuscitation, it will not interfere with the chest compression or defibrillation. Next. One is a umbilical artery catheter or umbilical vein catheter. It is usually used for newborn with first few days of life, usually for 5 to 7 days, but rarely used beyond 7 days. And it will discontinue after long-term vascular access is established. For UAC course, which is the artery, we insert the catheter through umbilical artery and it will reach into internal iliac artery, and usually used for hemodynamic monitoring. And for umbilical vein, it will be through ductus venosus until inferior vena cava. So it is used for delivering fluid, vasopressor, IV medication, central venous pressure monitoring. Okay. Next. So this is a picture that I want to show. This one, the first one is the how the procedure for internal jugular vein, And the next one is the femoral vein, and the last one is the umbilical vein or artery. Next. So the indication for central venous line, generally it is used for seriously ill ventilated pediatric patient, especially with difficult peripheral vein access, and then to obtain central venous pressure for monitoring and for hemodialysis. Next. And furthermore, it can be used for emergency resuscitation.
Kita makan dululah. Kalau dia okey, bulan depan baru kita cuba potong. Kita makan dulu. Kita pelan-pelan start balik. Kita makan dulu. Lepas tu sebulan yang datang, waktu 1 bulan lagi baru kita plan cuba water fluid pula. Okey, pakai dulu rescue dulu sementara kepada dia. Okey. Okey, now.
For other indication, it can be used for emergency resuscitation requiring administration of the large amount of fluid, placement of pulmonary artery catheter, frequent blood draws, and for longer term intravenous infusion. Next. Okay, so the contraindication for this procedure, it is contraindicated when there is an absence of training doctor for this procedure. And then if there is a bleeding and clotting disorder or non-thrombosis of femoral vein, is also contraindicated. And when there is a risk of contamination of the cannulation site by urine and feces, especially in the femoral vein cannulation. Next. And then it is contraindicated in patients with distorted anatomy or landmarks who have skin lesions such as cellulitis, burn, abrasion, and dermatitis. And the last one is condition that predispose patient to sclerosis or thrombosis, such as in vasculitis. Next. So the equipment needed for this procedure, generally we require a sterile set, and then lidocaine 1% for local anesthetic, 2 ml shrink, 23 gauge needle, 5 ml shrink and normal line, T-connector and 3-way tap, Seldinger cannulation, set shrink, needle, guide wire and catheter, and the last one is sterile jersey. This equipment for central venous access. However, for umbilical artery and umbilical vein, there are another equipment that you can read in later in PAPE's protocol. Next. Okay, the last one is a complication. We can divide it into acute and long-term complication. For acute, it can cause pneumothorax, vascular damage such as perforation and dissection. And then it can lead to air embolism, aberrant catheter placement, damage to thoracic duct, cardiac complications such as cardiac irritation and cardiac perforation. And then it can lead to local tissue trauma or damage, which is bleeding into surrounding tissue or nerve injury. Then for long-term complication, it can lead to infection and sepsis, thrombotic complication, phlebitis of granulated vessel, superior vena cava syndrome, and the catheter dislodgement and migration. Okay, next. So this is a link that you can see later. For this link will bring you to see the procedure of internal jugular line insertion and PICC. And the next one. Next. And this one will show you how the femoral line insertion was done. That's all for me.
Ambil femoral line. Ada femoral line? Boleh tak? Jalan. Femoral line tu boleh tunjuk tak? Video ada tak? Video femoral line? Zakira?
Ada.
Boleh tunjuk tak femoral line punya video? Berapa? Apa ni unbeliever? Apa ni? Apa benda ni? Apa Kaira ni, apa benda ni? Ni gambar ni, potonglah ini. Apa benda ni? Farah ni apa ni? Ini tube apa ni?
It's the video for the camera line.
You dah, mana dia? You tak ada pun?
Yang lain nampak ke?
Ha? Tak, smaller tributary not mean you have so apa benda tu?
That's the caption for the video.
Kaira apa benda tu? You dah tengok video ni sebelum ni? I dapat yang lain, I dapat gambar ni.
Skip je Hiza, skip je.
Sikit tu ke depan.
Oh, this one. Okay. Alright.
Tu Dia ada agama Hindu masuk sikit dalam. Salah awal lah. Tak apalah, you cancel lah. Kita ada banyak benda lain lagi. Kedua kan ada lecture lagi. You punya ni lambat sangat. No. Siapa next presenter? Cari yang proper sikit. Okay, black culture. Ada 9 presenter tak siap nanti sekarang. Dia boleh poor ke? You all presenter memang poor ke? Video you punya ni.
Kadang-kadang tersangkut sikit.
Ha?
Kalau video kadang-kadang sangkut sikit.
Ya. Okay, next. Siapa?
Ni, Nur Hazika.
Dia patut video ni dalam 3-4 minit dia. Tunjuk macam mana nak buat. Kita ada 9 presenter. Lepas tu pukul 2 you ada lagi. Hari kedua ada meeting. 12:30 dah. Next siapa?
So now we proceed to blood culture sampling.
Black culture. No.
Nur Hazika.
Azika.
Okay, next.
Okay.
So basically when we will do blood culture, when there is a clinical suspicion of bacteremia or sepsis, usually when the patient have symptoms such as fever, more than 38 degrees Celsius, chills and rigor, or any abnormality such as rapid respiratory rate or abnormal blood pressure, then we can indicate the patient for blood culture. So the equipment usually involve the venipuncture equipment such as disposable syringe and needles, tourniquet, sterile glove, mask, apron, and also chlorhexidine 2% in 70% isopropyl alcohol for aseptic technique. And also not to forget the blood culture collection container. Usually we use 2 blood container, which is aerobic and anaerobic blood bottles. Next. Usually for blood culture, the blood is obtained from peripheral veins and not from central venous. This is probably to avoid because the central venous usually have a catheter, which to avoid any catheter related bloodstream infection. And it is important because blood culture use aseptic technique. It is important to use to clean this venipuncture site, and also to apply the hand washing techniques properly to avoid any contamination. And also it is initially or ideally to take blood culture before the initiation of the antibiotics. However, the antibiotic can be start regardless the culture. You can start before the culture result is obtained. And usually it consists of 2 bottles and minimum for pediatrics of 3 milliliter of blood. For adult, usually 10 milliliter. And contamination is suspected when multiple organisms are isolated from the bottles. Okay, next. We can play this video. It actually comprehends of the steps.
Adult macam mana?
Adult, usually we take 10 milliliter each bottle.
10 mil. 10 mil, banyaknya. Okey lah.
We can watch the video. Okay, boleh start video. Basically from the procedure, we need to first inform the patient, the parents usually regarding the procedure, and also prepare all the materials needed, check either the bottles is not expired, and also the correct bottle culture used, and then also prepare the venipuncture site. Before that, hand washing, and then prepare the site by using the aseptic technique. Clean also the bottle, the cap, the above, and then when doing the venipuncture, and then make sure put the blood according to the blood culture bottles, and immediately send to the department, pathology department to analyze, to culture the blood. That's all from me. Any questions?
Any questions? Next. Siapa nombor 3?
Okay, so next is saya, Wan Nur Syahira.
Wan Syahira.
Wan Nur Syahira.
Syahira ya. Wan Nur, nak tengok Wan Nur tau. Okey lah. Apa? Bladder catheterization.
Bladder catheterization. Okay, so I will start. So bladder catheterization, what are the indications? It is indicated when we would like to collect sterile urine specimen for culture and urinalysis, and also for relief of urinary retention or obstruction, and to monitor urine output and assess fluid status. Okay, so bladder catheterization is absolutely contraindicated in patients with known urethral trauma and known acute pelvic fracture. Caution must be exercised in patients with anatomical malformations in lower urinary tract or those who had recent reconstruction of the urethra or bladder neck. Okay, so next. There are types of urinary catheter. The first one is indwelling or Foley catheter. It is a double or triple lumen tube with expandable balloon at the distal end. It is made of latex and silicone and usually used in when we would like to closely monitor urine output, for prevention or relief of an obstruction, and also for continuous irrigation of bladder. Okay, so the other types is the short-term or intermittent or straight catheter. It is a soft single lumen catheter made of polyvinyl chloride. It is used in collection of uncontaminated urine for diagnostic purpose and for intermittent catheterization in patients with neurogenic bladder. As you can see in the picture, the left one is the Foley catheter and the right one is the intermittent catheter. Okay, so next. Okay, so there are various sizes of the catheter, and choosing the right size, it actually depends on the size of the patient's urethra and generally the age of the children. Okay, so from my understanding, the sizes increases as the patient, depending on age. So for newborn, the size is usually 6 French course, and then going up to 8, 10, 12, 14, and 16 is usually for adults. Okay, so next. Okay, so before we start bladder catheterization, we have to make sure we explain the anatomy involved, the nature of the procedure, the benefits, risks, and complication of this procedure to the parents, caregiver, or patients. If the patient are able to understand that, if the patient are old enough, make sure we have the consent. And we also ask about the child's medical history for allergy to latex or any previous attempt at catheterization. Okay, so next. Okay, so the equipments needed are sterile water or saline or soap, sterile gauze pads and towel, absorbent pad to be placed below patient, sterile and non-sterile glove, a 10 ml syringe, pre-filled with sterile lubricant gel with or without 2% lidocaine, antiseptic solution, urethral catheter, sterile urethral swab, cups to collect the specimen, and forceps. Okay, so next. Okay, so this is procedure. I think we can go to the video to show better about how this procedure was done. Okay, kat minit kelima je. Okay, so this patient is placed in a supine frog leg position. And then after the absorbent pad was placed below, the external genitalia was cleaned.
Ya. Dekat 2A lah. Boleh baca obat, ada obat dia, baca je. Ya, ini kan apa obat dia? Ya, tapi obat dia sebelum ni apa? Apa obat-obat dia? Fadzil je. Ya, warfarin saja. Boleh tak? T40SH tak ada dalam tu result. Ya. Ini kan Miza kan? Miza macam mana? Okey. Sibuk dia ke sibuk? Apa nanti ini. Tapi nanti I go to nanti I order T40SH dulu di dunia tu dulu. Ambil darah dia tetap. Okey, tak ada T40SH saja. Okey, nanti hello.
Okay, Lisa, I think you can stop there. Can you go to the next slide, which is complications? Okay, so I will proceed. Okay, so complications of bladder catheter includes localized trauma of the urethra itself, which may lead to future stricture formation and creation of new passage, which...
Hello, some medical clinic. MUPD. Tak ada benda tak check case note lah. Dato Fadzil ni. Halo, ini Dr. Fadzil semula. Tadi kan siapa yang jumpa case note tu? Nama dia Dr. Staff siapa? Ini mana ni appointment ya? Yang ada satu staff nurse yang tu yang saya jumpa tadi, yang minta case note, cari case note tadi. Dia ada kat situ tak lagi? Lupa nama dia sebab dia pakai mask. So, bertanya dia, saya Dr. Dato Fadzil tadi. Datang tadi. Siapa yang pegang case note tu? Badaria case note. Medical lah. General, dia patutnya appointment endocrine general, tapi aduh, baru dia telefon saya tadi. Astagfirullahalazim. Salam, siapa nama you apa? Staff nurse apa? Alah, tadi kan dia Dr. Fadzil tadi saya datang. Lepas tu tadi saya ada beri satu borak form. Satu apa cari check case note. Nama dia Badaria. Lepas tu dia cari case note, dia buat course saya tadi. Jadi saya lupa, saya nak tanya siapa nama dia sebab tidak susah nak cari macam ni lah. Saya lupa tanya nama dia, saya tak nak cari balik siapa dia, saya tak tahu. Saya Datuk Fadzil datang tadi, pagi tadi. Saya datang tadi, case note, saya bagi buku appointment kepada dia. Tanya siapa dia nama, sebab nak silap sikit je, lupa tanya nama dah jadi macam ni. Dia buat course 5 minit tadi. Bilik kad dia depan sana tadilah, dekat pom 27. Aduh, nak pergi balik tu. Okey ha. Halo.
Assalamualaikum warahmatullahi wabarakatuh. Perhatian kepada semua kekitangan Sultan Ahmad Shah Medical Center, para pesakit dan pelawat sekalian. Waktu salat zuhur akan masuk dalam tempoh 15 minit daripada sekarang. Marilah kita bersama-sama menunaikan salat di awal waktu kerana Nabi Muhammad SAW pernah ditanya, apakah amalan yang paling terbaik? Lalu baginda menjawab, salat di awal waktunya. Untuk maklumat, salat fardu paling dilaksanakan secara berjemaah mengikut SOP yang telah ditetapkan. Adalah dimaklumkan bahawa tiada pelawat digunakan untuk melawat pesakit dalam tempoh PKPP. Hanya seorang penjaga digunakan untuk menjaga pesakit di ward pada satu masa. Sekian, terima kasih.
Semua presentation.
Okay, so I will continue. So complications of bladder catheterization includes localized trauma, as I said before, and also creation of new passage where the catheter pass through the urethral wall. And another complication that can occur is infection. Okay, so this is rare, but bladder perforation and catheter knot can also occur. And lastly, in patient with prolonged catheter placement, urinary retention may occur after removal of catheter.
Macam ni lah.
So that's all. Thank you.
Di klinik, ini Dr. Fadzil. Tadi kan ada satu orang staff dah telefon saya tadi pasal satu case note tu. Tak tahu staff dah lupa dia pakai mask, tapi orang veteran lah. Ni, tanya dia orang lah. Siapa ni? Hasri. Hello, Assalamualaikum. You Kak Long apa panggil you? Atur dah siapa nak contact nanti kalau apa-apa. Tak apa nanti saya call Miza. Siapa endokan? Fidah you beritahu dia. Saya call Miza dulu. Tanya bila appointment dia boleh tengok. Nanti saya go to Fidah. So saya nak ambil T4 T6 dulu. So nanti kan dia order balik sama je nanti. Nanti So standard Fidah Endokan. Okay, you Kak Long. Tapi you tu lah tak ada. So you pakai mask tak perasan you all. Okay, thanks. Terima kasih Okay.
Assalamualaikum warahmatullahi wabarakatuh. My name
Okay,
is Nasri.
Hassan.
Yeah, Hassan Nasri. I will explain about nasogastric tube and orogastric tube and its insertion in pediatrics. Next. Okay, the difference between orogastric tube and nasogastric tube is orogastric tube is inserted through the mouth and nasogastric tube is inserted through the nose. Orogastric tube are usually used in neonates because neonates are obligate nasal breathers. So we do not want to block the airway of the neonates by putting a nasogastric tube. So, however, in older children, we can use a nasogastric tube for next. For indications of nasogastric tube and orogastric tube are similar. It is mainly most commonly used for decompression of the stomach due to distal bowel obstruction, for example, due to exertions or hernias, ileus, obstructing neoplasm, volvulus, and intussusception, which is common in children. And also, it can also be used in intractable nausea or emesis to prevent aspiration due to gastric reflux. And we can also use administration of medications or nutrition if the patient have inability to swallow, for example, in have any neurological deficit or any abnormalities in the anatomy. Next. Okay. However, this nasogastric tube is contraindicated in significant facial or trauma of the to the face and also basilar skull fractures because it can have complications during the insertion where it can malposition, where it can be inserted into the cranium fossa because of the fracture. It is also contraindicated in esophageal trauma, for example, in after ingestion of caustic substances, and also esophageal obstruction because it can lead to esophageal obstruction, esophageal perforation. Okay, it is also contraindicated in esophageal or gastric varices because it can cause massive bleeding because of the rupture of the varices. However, it is only relatively contraindicated in patient on anticoagulants or thrombocytopenic because we need to monitor the chance of bleeding during the procedure. Next. Okay, for the procedure, first we prepare the equipment. First, we select the type of the nasogastric tube used for what purpose. For example, in Salem sump tube, which is usually used for aspiration, and it can also be used for feeding. However, Levin tube and Dobhoff tube is mainly used for giving nutrition and also medication. It is not used for suction. This is, you can see the pink one, the difference where Salem sump tube is a double lumen tube and the Levin tube is a single lumen tube. The Dobhoff tube is similar to Levin tube, however, it has a weighted at the end, at the tip end of it for the patient able to swallow, so become to let the gravity lead the tip.
Ini adult kan?
Yeah, adult.
Pediatric kita tak pakai Salem Sum tube, Levin tube, Dohoff tube.
Oh,
Dia pakai NG tube je.
okay.
Kau terima.
Next, this is the measurement. For nasogastric tube, we measure from the nose until the lower part of the earlobe, and then to the midpoint of the xiphisternum and the umbilicus. We take the midpoint in infant and also older child. Okay, next. Okay, for the positioning, in patient who is awake, we prop up the patient in semi-upright position, and if he's sedated, we lay down on the bed with the head of the bed elevated so it is slightly upright, and the head facing to the left to prevent if the patient have vomiting, he can put vomiting back on the side. Okay. And then we lubricate and advance the tube with a firm constant pressure through the nose with the tip directed to the back of the throat. We do not aim the tip upwards. We aim directly towards the back of the throat. And if the patient is the older patient, we can ask him to swallow and sip water, and we put it while he is swallowing. And after if it is inserted correctly, we secure the tube to the face with a small piece of tape. However, in children, we do not apply on the nose because the nose, if we apply on the nose, it will obstruct the breathing. So we apply on the tip of the on the side of the nose, on the side of the mouth. However, during the insertion, if the patient have any signs of choking, coughing, or difficulty in breathing, we must immediately remove the nasogastric tube because highly likely that it is already put into the trachea. After patient have more stable, we with cooperative gain, we try again to insert the tube, however from a different angle. Okay, next. Okay, after we insert the tube, we confirm the placement by using a syringe, a large syringe to push air into the stomach while we auscultate the stomach. If we heard the auscultation, the sound, whoosh sound, then it is confirmed in the stomach. However, it is not very accurate because in children, if it's the sound is in the lung or the stomach, probably similar because of the size of the child. So the next step is to test the pH of the gastric aspirate. We use the syringe to pull out the gastric fluid and test the pH whether it is 5 or less. If it is 5 or less, it is to more or less confirm. However, the gold standard to confirm the placement of the nasogastric tube is by chest X-ray. Next. Okay, for chest X-ray, we use radiograph, and we identify the landmark and also identify the radio opaque nasogastric tube, which is supposedly straight down to the midline and then curve to the left of the patient. And this is, you can see if it is deviate to the lung, it is likely to be in the respiratory tract. So we remove the tube and retry to insert it again. We do not use the feeding tube unless we confirm it is certainly in the stomach. Okay, next. Okay, the complications can be divided into during insertion and also during use. During insertion, small position, which is in can be if we malposition, can be into the trachea, or if more severely into the through the cribriform fossa into the cranial fossa, which is highly dangerous. And we can also have esophageal or gastric perforation if we force. So during the procedure, we do not force the tube if we encounter obstruction, but using firm and constant pressure. And we can also, the patient may also have vomit or aspiration. So we put the patient into recovery position. And if during use, during long-term use, it can also cause sinusitis. Also unplanned dislodge or migration, because the children usually move about. And so we need to, every time we feed the child through the nasogastric tube, we need to inspect the location of the marker, how the length of the tube, it is dislodged or not. And then it can also cause blockage if sometimes in the tube. So if it occurs, we to remove and insert it again. Next. Okay, that's all for me. Any questions?
Ada video?
Ada dekat link tadi, dekat references.
Ya. Tunjuk mana?
Ni.
Boleh tak?
Boleh skip ke minit ke-6.
15 minit, ui lama je.
You can see my confirmatory spot is right there. And that would be important to know every time you approach this patient if you're going to put anything into the tube. Note the tube is where you put it when you put it in. I'm going to get this hooked up now to the section.
Okay, next. Kenapa? Siapa next one?
Sorry, doctor.
Doctor, if we didn't get to finish it by today, we have another schedule for procedure presentation next week.
Yeah, tapi I'm busy. Easy for you, not easy for me. You think I only teaching you all saja ke? No earlier.
Okay, so we move on to the next procedure, which is chest tube insertion. Okay, next.
Biasanya present berapa usually one time? Jadi dua kan?
Dua session.
Usually 5-4 kan? 5 today, 4 next one kan? So I thought you like that. So chest tube come. Last one chest tube. Dia 5-4 kan? Next week bila?
Wednesday, 2nd December.
20?
2/12.
Okay.
Okay. So what is it? It is a procedure used to evacuate an abnormal accumulation of fluid or air from the pleural space and can be performed on an elective, urgent, or emergent basis. So next for indication. Next slide. Okay. So when there is a prolonged drainage of air or fluid such as empyema or hemothorax from the pleural space, and for definitive treatment of a tension pneumothorax, which is after needle decompression. Okay, next for contraindication. So for contraindication, absolute there is none. For relative, there is if there is a bleeding disorder or presence of adhesion which may require pleurodesis. Okay, next. Okay, so these are the list of equipment which include shoulder roll, pain medication, tegadem, monitoring equipment, chest tube, antimicrobial scrub, scalpel, sterile gauze, Kelly clamps, suture, needle driver, suction source, drainage collection, and male-to-male connector. Okay, next for preparation. Okay, so for patient preparation, patient should have IV access oxygen should be available, monitor oxygen saturation. Younger patient may need sedation or anesthesia for procedure, and we need to explain the procedure and obtain consent before the procedure. So for patient positioning, patient lying on bed with head or table elevated 30 degrees with arm above head. Okay. Next for procedure. Okay, can you play the video?
Buka balik semula. Terbalik semula. Okay. Okay, Ini
For the procedure,
kalau
play
budak
the
tu
yeah.
kooperatif sometimes baby kita buat ni terus tak 30 degree pun. Okay, continue
Okay.
Continue.
Continue. Next slide. Okay, can you please play the above video? Oh no. The black one.
Intercostal space just
we find at 4 or 5 intercostal space.
Mana dia?
Sekejap. So we first find the 4th or 5th intercostal space. They usually below the nipple. So patient lying with the hands above the head. So we drape the place and then we insert local anesthesia. And then we make the incision parallel to the intercostal space, about 2 to 3 cm. Then we introduce the hemostat. So we introduce the hemostat into the parietal pleura and finally into the pleural cavity. We make the incision bigger. And then we insert the tube with the Kelly clamp. And then we connect to the pleural bag. Okay, that's all for procedure. Okay, next slide. Improper positions such as placement into subcutaneous tissue or peritoneal space, risk of pneumothorax, bleeding from intercostal vessel that can create hematoma or hematothorax, puncture of liver or spleen, infection and laceration of lungs. Okay, next. Okay, these are the summary for the indication, contraindication, complication, and the equipment. Just overview. Okay, next. Okay, that's all from me.
Okay, next. Okay, no Zahira, you SEL, no Zakira, no apa? Zakira, Apa no Zakira?
Yes, saya.
Okay, you yang intracranial apa tu? Vessel tu kan?
Central line.
Central
Venous.
line. You kena present semula. You kena cari video balik semula.
Okay.
I nak video yang proper sikit tadi video campur agama Hindu tadi. Indonesia part tu dah apa-apa dah Maira dia punya Hindu punya tu punya. You check betul video, cari video yang fokus terus pada ni. Yang muka orang India kan cakap banyak je jangan ambil lah. Sebab dia orang ni banyak pusing-pusing nanti. I think this one you ada Indian punya medicine apa nama dia? Tu. Dia involve, dia terlibat tu, cari yang tu sikit Yang tu. Line ni kita buat pukul 12 hari sama minggu depan pukul 12 Dia just the aim is Syah. Oh, misal lebat misal Syah. Misal you lebatnya. Simpan janggut lah wah. Dia simpan ni macam aturol nanti. Itu aturol tak? Nak cerita aturol? Tak tengok? Tak tengok cerita tu. Aduh, I sampai waktu episod ke 100 berapa? 200 lebih dah. Simpan janggut lawa tu Okay, this one you presentation ni is more introduction to you all. Tak keluar dari exam pun nanti. Kalau keluar pun mungkin indication saja. Apa indication blood CNS itu saja kita keluar dalam MCQ je. Cuma you all have to recognize sebab banyak komplain mengatakan bila you all pergi sana buat jadi SO you tak tahu apa. And furthermore, because not like before, last time kita orang dulu banyak prosedur, jadi kita orang tengok cari blood CNS kita follow. Sekarang ni it's not like ni, so at least you know something about the procedure. And so the aim is indication ni semua. Lepas tu complication, everything standard practice lah. Bila you technical part tu tak boleh detail sangat. Because best is kita pakai video. Step by step ke video tu lagi manusia ni kalau visual ni bagi your generation ni tak boleh cakap banyak. Your generation banyak visualize generation. Tengok benda tu lagi you lagi dapat pick up. So your generation is visualize generation or screen generation. Visualize. Jadi bagus tu you ada video tu tapi dia jangan panjang sangat standard practice 5 minit cukup dah tapi cari tempat yang tak tersekat-sekat lah tu sangat ke sekarang ni your punya line teruk
masa hujan lebat teruk sikit lah.
Ya hujan lebat macam mana kita
hujan biasanya petang.
Ya. You kat mana banjir sekarang? Kat mana? Banjir tempat you all. Banjir tak?
Tak.
Tak apalah. Okey, tak apa kita buat minggu depan. Cuma yang video essay tu kena repeat semula Okey. Okey. Okey.
Okay, thank you Dato'.
Thank you Dato'.